You're listening to a Raconteur Studios podcast.
Hello and welcome to the After Hours Skin Clinic, the podcast that keeps the skin chat going well after the clinic doors close. I'm Dr. Emma Craythorne, consultant dermatologist and host of the After Hours Skin Clinic, here to give you expert advice on your biggest skincare questions, the kind of things I get asked after hours, on a walk in the park, at the school gates or over a glass of wine. If you like what we're up to here at the After Hours Skin Clinic, please do give us a follow, share this with your friends and family, or give us a shout out on social media. It really helps people find us. Now, today I'm joined by my friend and fellow consultant, Dr. Ellie Rashid. Hi, Ellie.
Hello. Thanks for having me.
Now, this episode is going to be all about rosacea. This is a skin condition that affects over 5% of the population worldwide. It's a lot of people. Now, you may or may not be aware that it's Rosacea Awareness Month, and we've been asking you to send in your questions so that we can give you expert answers and help you really understand what rosacea is and how to treat it. So let's start off with, what is rosacea?
So rosacea is where patients develop this chronic inflammatory skin condition. It normally results in redness of the cheeks, the central parts of the face, so the nose and the cheeks, but it can affect the chin and forehead as well. It typically affects people from their 30s and 40s onwards.
I actually think we see it a lot now in teenagers who mistakenly might think they have acne and start treating their acne, but actually it is rosacea. So
yeah, I've seen that on a few occasions before as well.
Yeah, so it can really start very early in life, but most people, it's around the 30s or 40s where you're seeing it mainly presenting, isn't it?
Yeah, and they get this flushing, swelling, they get this enlargement of the oil glands, they can get this sort of thickening of the skin, and they get these blood vessels that look a lot more obvious on the surface of the skin, like these little broken vessels. And again, in a similar sort of distribution, central face, forehead, and on the chin.
I sometimes think of rosacea in those people who have a dry rosacea. So I'm thinking where those oil glands are actually not that active and the skin's a bit dry with it. And they can often be people who are describing things like stinging and burning. So sometimes they don't even have that much redness. They just have this stinging and burning and a mild redness and dryness on the skin. And then I think of the other side of rosacea being those ones that it's much more oily skin and they get those papules and pustules. That's the way I kind of split it in my mind.
The stingers and burners.
The stingers and burners, yeah, exactly. And the spotty ones. Now, when we think about rosacea, we divide it up into different subtypes. And do you remember when we first started in dermatology, you would say somebody had a papulopustular rosacea, meaning that they have lumps. And that was it.
And that was it. Yeah, couldn't overlap with any other type. Absolutely.
But now we know that you've got multiple different types can often coincide together. And rosacea is actually this little blanket term at the top that covers all of these subtypes of rosacea, but they're all mixed in together. So should we go through what they are?
Yeah, let's go through it. So at the top, maybe we start with ocular rosacea, because some people don't realise that rosacea can actually affect your eyes as well. So the symptoms that people will get with ocular rosacea is this gritty sort of sensation in the eyes. It can feel dry. It can feel like there's sort of sandpaper. It's like there's sort of sand in your eyes. It's uncomfortable. Their eyes can be quite red. So it's really important to recognise that that can happen, because if you don't realise it can happen, you might sort of dismiss it down to sort of an allergy or something and not necessarily mention it to your dermatologist.
I think it's actually something that people often forget to mention. And even as, medical professionals, we sometimes forget to ask people who have rosacea whether their eyes are affected. And they might just think, oh yeah, I always get crusty eyes, or I always have this irritation with my eyes, but not actually put two and two together.
Yeah, I had a patient the other day with ocular rosacea, and the thing that he really said was, since he's treated his ocular rosacea, people have commented on how lovely his eyes are, because they're really lovely blue colour, but it's always been this redness in the background, always quite inflamed. And he said, I'm now getting compliments, and I realised how much it was affecting me before, now that things have improved, that people are now complimenting me.
I think it is one of these things that sometimes people just think, oh yeah, I've got crusty eyes. Oh, I've got, dry eyes. They're always red, my eyes. It's an allergy. And just dismiss it. But actually over time that gets compounded, doesn't it? Until it's a bit of a problem.
Yeah. And the next type would be the telangiectatic type. So these are patients that have mostly the redness, the broken vessels that you can see on the surface of the skin. Sometimes they have like a fixed redness, which is the broken vessels, and they can get this significant flushing, and it can be really painful, as you said before.
Yeah, exactly. And then we have the pustular type of rosacea, where you're seeing these bumps on the skin, and they can look a little bit like acne spots. So sometimes if people are just getting those, they might think, oh, I've got acne, rather than it being the rosacea. And these are little bumps. Usually, again, they're on the cheeks, the chin. Sometimes you'll see them scattered across the nose as well. And then even these little bumps can extend up around the eye area. I've even seen it on the chest and the neck, biopsied it, and that'd be rosacea as well. These little bumps can sometimes have bits of pus in them, so that's why they get called pustules. So you've got your papules and your pustules.
And then finally, we've got the phymatous rosacea. So phyma means where you get this dilatation or thickening of the oil glands and thickening of the overlying skin. And it usually affects the nose and the medial cheek, so just the cheeks next to your nose. And it can look really dramatic. It can affect the entire shape of your nose and make it look quite bulbous, quite swollen.
And really problematic. Do you remember the patient I just showed you yesterday?
Yes, that's exactly what I was about to say. Yeah.
He can't breathe through his own nostrils because the nose has become so big that it's compressing and squashing his nostrils down.
It was even squashing his eyes because of the thickness.
Yeah, so he started off with his rhinophyma, rhino meaning nose, phyma meaning the thickening, and then it had extended to his cheeks. It was actually all the way on his upper lip as well to begin with. He's getting treatment now whenever I showed Ellie the picture. But yeah, he had no nostrils. You couldn't even get in to see them. And then I've had some other people who have had really quite dangly bits of their nose coming down into their mouth. I've had people be able to get their nose tip just come into their mouth because it's expanded so much. So it can be a real problem. I think it's also a problem because people often assume somebody with a big red nose is an alcoholic, or they've been drinking, or they have some other kind of issue that is more than just a skin problem.
Yeah, I think so too. Because when you drink alcohol, you do get a red nose, you do get flushed, and things can look thickened with chronic alcohol. So yeah, I do think that really bothers them, that people may make that assumption incorrectly, but sometimes correctly.
Yeah.
Maybe they've got rosacea and drink excessively.
So one of the questions that we had come in refers to, is somebody who has severely sun damaged their skin in the past, is this something that could have led to their rosacea?
So UV radiation is a trigger for many patients that have rosacea. And some studies have suggested up to 81% of patients will have UV as a trigger for their skin. So UV isn't a direct cause of rosacea, but some of the changes that you can get on your skin as a result of sun damage can look quite similar to rosacea. So you can get these broken blood vessels, the collagen degrades with UV radiation, so the skin can look quite different, can thin a little bit, be more reactive, be sensitive. So it doesn't directly cause it, but the features can look quite similar, and it can be a trigger for rosacea. So it might be that she's got rosacea and it's just made her skin a lot more sensitive and a lot more red and a lot more reactive.
So I think that probably when we think about what actually does cause rosacea, there's probably a number of different factors, isn't there? First of all, we think about that it's within your immune system is the real reason why. So something about the way that your immune system is programmed means that you're reacting more to things that are in the skin that perhaps somebody else wouldn't necessarily be reacting to. One of those things that people can react to are little Demodex mites. Now, we all have these little spider mites, and these spider mites live down our follicles. They, have a nice little time in your follicle, and at night time they come up and they gobble up all of the sebum that sits on your skin, and then they copulate, and then they head back down the follicle for a good day's sleep. That's the life of a Demodex mite. Pretty nice.
Sounds like a great life.
But what happens for some people is they have more of these Demodex mites, and that might be the problem, or their body is reacting to the Demodex mites. And actually, sometimes we think it might actually be the death of the Demodex mite is the problem, because the bacteria that resides within the mite itself, whenever it's released into the skin, that might be the trigger. So that's just one element. We also have the ultraviolet radiation problem as well. And then our immune system issues, as well as having things like vascular changes that occur within our skin. So for some people who have rosacea, in response to things like ultraviolet radiation, they release a chemical that tells the skin to make more blood vessels. This chemical is called VEGF. So more of these blood vessels are then created. So that's partly, I think, how we can then sometimes relate some of the features with rosacea with excessive UV exposure.
And then the other things that have been linked to rosacea, which I find super interesting, is the gut microbiome and its link with rosacea. So this is really clever, but on our surface of our skin, we have these little stress receptors, and those stress receptors are called TLR2 or toll-like receptor 2. And then when it senses a threat on the skin, it overproduces this molecule, which is part of our immune system, called cathelicidin. And it's this cathelicidin that then upregulates an immune response, which is where you get the inflammation from. And the link with the gut is that these gut-derived toxins or microbes can fuel this immune reactivity through the bloodstream. Which I love this sort of thing.
I know you do.
I really do.
Because this is gathering, quite a lot of traction. And many of my patients with rosacea will come in and say, I'm going to change my diet. Do I have SIBO? All of these things that are potentially linked with rosacea, but actually only in a very, very, very small number of people. So I think maybe we should talk a little bit about that.
Yeah, so SIBO, S-I-B-O, the acronym stands for small intestinal bacterial overgrowth. And there have been some studies that show a high prevalence of SIBO in rosacea patients. But then the real question is, what do we do about it when you've got a diagnosis of SIBO? So the way it's diagnosed is you do a breath test that looks at hydrogen in the breath. It's not a very reliable test, so it could be a false negative or you could get a false positive equally. And the way we treat SIBO, so it's not funded on the NHS, is the first thing to say. So people would have to pursue treatment privately. But it's an antibiotic called rifaximin. And rifaximin is an antibiotic that isn't systemically absorbed. So you take it orally, but it goes into the small intestine and it exerts its benefit directly onto the small intestine without much in the way of side effects. So very well tolerated, but quite an expensive treatment and not funded on the NHS. And then in terms of, if you treat your SIBO, how much of an impact will it have on your rosacea? Well, the jury's still out. The studies aren't very conclusive, and so there's no guarantee that managing SIBO accurately would definitely result in an improvement in your rosacea.
And I also just find it quite interesting that the antibiotic that used to be used to treat SIBO, and actually still is if you're not going to pay for the dear one, is exactly the same antibiotic that we use to treat rosacea.
Doxycycline.
Yes. And then, of course, it really comes down to our genetics. So, researchers have really found that rosacea is significantly more common in identical twins. So in other words, if one identical twin has it, then it's much more likely than the other one will have it as well. But even then, environment plays a huge role, probably making up about 50% of those people who then present with rosacea. So yes, it may well be in with your genetics, but there's certain things that you'll be able to control within your environment that really will determine whether you get rosacea or how bad that rosacea might be.
We've had another listener question, which is, what are the most common triggers for rosacea flare-ups in terms of food and lifestyle?
Well, there's lots of different triggers and the triggers are not the same for everyone. So I would often say to patients, okay, I want you to keep what's called a flair diary. So when things go bad, just keep a record of this for the next 3 months. And then after that, don't kind of beat yourself up about it. That's your diary done. Don't keep doing this for forever because it's annoying. But to see if you can find out what those triggers might be. So probably the number one trigger people tend to find is UV exposure. So it might even be a cold day, but the sun is out and it's bright, and that can often be a flare. In my clinic, I'll see patients, particularly whenever the humidity levels are very low. So when the weather is cold and the humidity levels are low, it means that we're losing water from our skin. And those people who, particularly those burners and stingers where the skin barrier gets a bit disrupted, then in those conditions, it can also cause a flare. And the same thing's true for being in places that have low humidity that are inside. So whenever we central heat our houses, they therefore get very low in humidity, and you get this exchange of water, and that can often result in a flare. So those main triggers are things like ultraviolet radiation, changes in the temperature, particularly going to these low humidity environments. Things that people do are particularly things where you're increasing the blood flow through your skin. So that can be drinking alcohol, it can be eating spicy foods, it can be going to the gym and doing exercise. They, for me, are probably the top triggers that people would identify to.
Yeah, I also notice with yoga, so people don't associate yoga as like an exercise where you're sweating a lot, but you're getting in positions where you're increasing the blood flow to your head and neck. And even that I've seen can really trigger people's rosacea.
I mean, the next thing really is certain foods that some people eat, other than just spicy foods, they feel can trigger the rosacea. So foods that have got a lot of histamine in it, for example. So sometimes things like tomatoes or strawberries. And then obviously things that you put on your skin. So for some people with rosacea, that skin barrier has just been almost not destroyed, but it's not functioning very well. And if the skin barrier is not functioning very well, then you get this increase in inflammation in the skin anyway. And so if you're applying topical treatments to the skin that might disrupt the skin barrier, so I'm thinking things like acids, things like soaps, all of these foaming agents, that extra disruption can then cause flares of rosacea. I think actually one of the worst things is just washing your face with some soap if you have rosacea. I mean, you're going to get into a bit of trouble with that.
Who uses soap?
Lots of people.
Oh my gosh. I think you can now get cleansing bars.
You can.
Which are brilliant, like thinking about the environment and, just having a bar, which are much better than using a traditional soap, which just completely strips your skin.
So you'd look for them. These are called synthetic detergent bars. I think Dove do one. I think Cetaphil do one. CeraVe do one. I think they might do.
Syndet for short, sometimes they're called.
We get quite a few questions about whether red wine is more problematic as an alcohol than other drinks. What do you think?
Historically, with alcohol, people always assume red wine is the worst culprit when it comes to flaring rosacea. But actually, studies have shown white wine can sometimes be even worse compared to red wine.
Yeah, that's right. I think it's all alcohol, because all alcohol will cause dilation of the blood vessels. And so it's going to worsen the redness of the face. However, whether there's a certain type of alcohol is going to be a problem or not, who knows? And yeah, I saw that study as well. It's a good one. It's interesting, one of the questions that came in, it's actually more of a comment to say that she had been diagnosed for many years with eczema and had been given steroids to treat her eczema, but actually all along it had been rosacea. And this is something that I would see from time to time in my clinic. Probably at least once a month I would have somebody come in with either a misdiagnosis in a way and have been given steroids to treat eczema, but it's actually rosacea, or have been using steroids themselves on their face and actually given themselves rosacea, because we know that using topical steroid in the face is a really high risk trigger for rosacea.
Yeah, so for many skin conditions, we are going to use topical steroids to reduce inflammation. And so I can understand why topical steroids may have been given. You've got an inflammatory component to the skin, it all looks inflamed, swollen. And so I can see why the misdiagnosis happens. But then really it's in the symptoms not getting better with the treatment, if anything, making it worse.
I know, because one of the things I suppose is you put steroid cream on rosacea and it does get better. It gets better for a couple of days and then it just gets so much worse. And then you put it on again and it gets a little bit better, but then a day or two later it gets so much worse that each time it just gets worse. So that is never going to be the answer for treating rosacea, and is actually sometimes the cause of why someone has it in the first place. Shall we move along to what we do to treat rosacea?
Yeah, let's.
So I'll start with my first and most important thing, trying to help someone understand why they have it. I actually think that's part of the treatment, because we're thinking about somebody who has a condition that they have probably had for many years before they even come to see you, and will continue to potentially have in the future for a long time unless they keep up with the skincare routine or the treatment plan you put in place. the idea that you're going to give somebody a cream for 12 weeks and then that's going to fix all the problems and it's not going to come back. They have to understand that it's not like that. This is something where you will make modifications to what you do every day. And it's those modifications that will keep the rosacea away. But if you don't keep it up, it'll just creep back in. So I often have that conversation first. And then the next thing I'll do is to try and identify what those particular flares are for that patient. So I do keep a trigger diary, because the more you get a flare or a redness or a flush or a burn, each of those times, you're adding a little bit more fuel to the fire of rosacea. So it's about trying to keep that as calm as possible. And so that's where this trigger diary comes into play. And you can do downloadable trigger diaries from the Rosacea website, rosacea.org. And on that website, they have one that you can just download with all the common triggers and keeping a diary of that. So I say to do that for 3 months. So that's actually step 1 of my treatment plan for rosacea.
My step 1 for my treatment plan is to categorise which subtype of rosacea is the most obvious on their skin, because the treatment options, often things like the papules and pustules, you can get better quite quickly, but sometimes the redness and the sensitivity and the flushing is a little bit more difficult. So you just want to be really obvious. So these are the signs and symptoms that I can identify. These are things that will very likely get better quite quickly. And this is the time frame for other things to get better. Or maybe we need a different type of treatment approach. So yeah, I would want to know their triggers, and I'd also want to categorize them to see how I can help in the most effective way and in the quickest time possible.
Yeah, so I think that's key. Understanding what are the features in front of you, and then what is the best thing to treat those individual features. Because sometimes it's a cream, sometimes a tablet, and sometimes it's a laser. So it all depends on exactly what you're looking at.
We should probably start with ocular rosacea, because most of the things we talk about are for the skin manifestations. But so for ocular rosacea, I know that ophthalmologists will often treat this. Sometimes they use a steroid-based eye drop, and they use a weak steroid just so they don't affect the pressures of the eyes. And then they move on to these immune-suppressing ingredients, but in the form of an eye drop. So cyclosporine eye drops are the most common. And then hydrating and lubricating drops or ointments as well, just to help with that gritty, dry sensation they might get. Another great treatment that they can do for ocular rosacea is this intense pulse of light that's used to treat the eyelid skin and the skin just around the eyes, and actually even been shown in studies that you can treat the forehead, and that can help with ocular rosacea symptoms as well. So you put an eye shield in to protect the eye itself, and then the IPL treatment is done over that area that's affected.
And then we think about how we can treat the signs on the skin. So first of all, it is about having a very basic skincare routine. So protection from ultraviolet radiation is key. So you have to find the SPF that you really like to wear. It doesn't matter about whether it's mineral or chemical. It has to be one that your skin finds very comfortable, and that is key. And it needs to be put on every single day, because it's the UVA that's often problematic, and that's obviously all year round. A very gentle cleanser. Not a soap cleanser at all. No foaming cleansers are allowed. And then your moisturiser has to be a gentle moisturiser as well. And then applied at nighttime is your topical treatment. Now, the topical treatments that we know are effective for rosacea are 1% ivermectin. And that is being seen in head-to-head studies as being the best topical ingredient to apply, the medicine 1% ivermectin. Second to that is 15% azelaic acid. And then third to that is 1% metronidazole gel. And that is the order of how effective they are compared to one another. Sometimes for trying to restore and build up the skin, the use of tretinoin can be very helpful. And that's also helpful for the redness that can occur with rosacea. So the combination of this very simple skincare routine with these medical agents in that order are usually what's considered best practice. And then if that's not enough, then you can move on to some of the oral treatments.
So oral treatments that can be really helpful, often in the form of antibiotics. So one from the tetracycline group, either limacycline or doxycycline, most often is first line. But we're not giving these antibiotics to treat an infection. We're using them to treat inflammation and reduce inflammation. So you often have to have them for a longer period of time. So a minimum of about 4 to 6 weeks. but most cases it's between 3 and 6 months. And in some inflammatory skin conditions, we would continue limacycline or doxycycline for a period that's even longer, so up to about a year, to try and get on top of the inflammatory component. Then in terms of other oral treatments, we can sometimes use a vitamin A ingredient tablet called isotretinoin or Roaccutane. Now, in acne, we use this exact same treatment, but we tend to start low and then go relatively high, and the treatment course is about 7 months. But in rosacea, we do things differently. So you start low and you stay low, and it's usually given over a longer period of time. So usually for about sort of a year or 18 months, but at this low dose.
But I think it's really important to know that if you're somebody who feels that you're in a repeated cycle of antibiotics, that there is another option. It can sometimes be a little bit more difficult to access, but guided with your dermatologist, there is that other option.
We've had a listener question come in. What type of laser treatment is the most effective? And does IPL really help with background redness and flushing? And how many treatments do you need?
Well, we're now into the wonderful world of lasers, which is obviously my favourite play toy. And I treat almost all of my patients with a laser device as well. And it can be either using a laser that's specifically targeting redness, so whether this is the background redness, or whether it's targeting the blood vessels that have formed, these little telangiectasia, or whether it's using a laser to treat the large bulbous nose that can occur, where I use a different kind of a laser called a carbon dioxide laser to reshape those very, very misshapen noses. Not all IPL devices are equal. So having an IPL treatment with one particular device with one particular practitioner does not equal the same as having it perhaps with another device or another practitioner. And so it's very hard to say that it's going to work in every circumstance, but with the right parameters, with the right device and with the right practitioner, usually you can get a mean clearance of that background redness of rosacea by around about 77%. And that is with a mean of around 4 treatments required. So that was from a published study in 2005, and it's really kind of remained the same since, even with new devices coming on the market. So around about 4 treatments and you get this 77% clearance.
And the IPL device, I really love for that background redness, as you say, but sometimes to treat those individual vessels, we've had a listener question in to say, is thermocoagulation or vein wave treatment more effective than a laser? And the answer is that the thermocoagulation might be helpful for little individual vessels, but it wouldn't be good if you've got lots of these broken vessels on the face, and it doesn't perform as well if you've got lots of background redness. So background redness I treat with IPL, and then if they've got more of a redness component or a purplish component, then some of these vascular lasers can be a little bit more helpful.
So when we think about vascular lasers, we've got the IPL is just, well, it's actually not truly a laser, but it is an energy-based device that can target red. And then we have lasers that are very good at targeting red. So like a pulsed dye laser, which is the laser that you would see often whenever we might be removing port wine stains, or a KTP laser. All of these devices are used for rosacea. And it's really hard to pit one against the other. I mean, it's, you can't really say one is necessarily better than the other because some are good for some functions and some are good for other reasons. So one of the questions is, if you have telangiectasia, so these little blood vessels that sit on the face and the nose, what is your go-to for just getting rid of them? Because creams are not going to work for this, so don't think any cream you're going to buy is going to make any difference. But what is the most effective treatment that you find in your practice, Ellie?
So I absolutely love using the Derma-V laser. I just adore it. And you see the little blood vessel grey out in front of your eyes. And often you need a couple of treatments sometimes, and the problem is solved.
Yeah. So it's a very quick, pretty pain-free treatment. It can be done within 5 minutes and that just clears those blood vessels. Now, they will come back because they're under pressure from other vessels deeper down. But, you can get a good year or two clearance of these being gone. So if it's something that you feel that you have to cover up every day and is a bit annoying and problematic, a decent laser treatment with something like the Derma-V is going to be very effective.
So we've got a few final questions that have come in. So the first one is, does rosacea affect people with skin of colour?
Well, yes, it does. I mean, You will see it more commonly in people who have fairer skin types, and particularly people of Celtic descent. But actually, it can affect all skin colours. People who have very white skin are slightly more susceptible to that ultraviolet damage and therefore are going to get more symptoms of rosacea. But it is present in people who have brown and black skin. Now, what I always find so difficult is if you were to go on to Google, for example, and do an internet search for the term rosacea, you really never see anybody at all with skin of colour with rosacea. It just doesn't come up. And I think that's why it can often go undiagnosed for many years, because it's just not even thought about.
And it's unclear whether it's because it's not being diagnosed or whether the prevalence is truly lower. There's this large epidemiological study looking at US data. So this is US National Ambulatory Medical Care Survey between 93 and 2010, looking at 31.5 million rosacea visits. And 2% of patients were Black, 2.3% were Asian or Pacific Islanders, and 3.9% were Hispanic. So definitely does affect a proportion of people, but it's probably underdiagnosed, exactly as you say.
Yeah, small number, but that's not even represented, I don't think, on an internet search. Not even 5% is represented.
Yeah.
And we get lots of listener questions about a skin routine if you have rosacea. So what would be your top cleanser that you recommend?
My top cleanser is La Roche-Posay Toleriane cleanser. Mine
would be Cetaphil Gentle Cleanser or the Hado Labo Oil Cleanser.
Which is out of stock everywhere.
I know, my fault. Okay, what is your favourite moisturiser?
Favourite moisturiser is the La Roche-Posay Toleriane moisturiser. Or actually, I like the Avène as well. The Tolerance range by Avène is good.
I like Avène Tolerance. I like La Roche-Posay Lipicar Balm. I do like the Toleriane as well. And the really most important one is the SPF. What do you pick?
So I like the HelioCare. Lots of patients with rosacea seem to like it. So they've got like an oil-free gel, which is quite light and not greasy.
I like the La Roche-Posay Invisible Fluid for children. So it's in the same bottle, but there's got little children in the corner. So it's really moisturising and it doesn't have lots of stingy factors in it that sometimes people complain of whenever it can get around the eye. So that'd be my number one.
I guess one of the important things about rosacea that we've not touched on so far, it's the emotional impact that this can really have on people. It can affect their work life, it can affect their social life. When you think about going out and eating, drinking, and they're getting flares of their rosacea, it's uncomfortable, it's painful, they're needing to go home, or they'll just avoid socialising altogether. It has a huge impact on people's lives.
Yeah, I mean, it really does. In fact, 2 of my patients today, just in clinic, that's exactly what they commented on, that they would not want to stand up and give a presentation at work. They, would avoid even going out of the house and just, not interacting with anyone because they felt so embarrassed about the way their skin was. And then when I think of some people who have their phymatous disease, so the large global changes to the nose, and they just become social recluses. But even the very milder form of rosacea, where you've just got this little smattering of redness and you've got these pustules appearing in the central part of the face, people feel stigmatized because they have it and they don't realize it, but it builds up over time. They just see a little bit and then a little bit more and a little bit more, and they adjust their behavior because of it. And only when it's stopped, whenever they decided to come along and have a discussion with a doctor about it, do they really realize the impact that it's been having on their life, often for many years.
Yeah.
Right, that's a wrap for today's episode of the After Hours Skin Clinic. I hope you found this episode interesting and helpful. And if you know someone who'd like it, then do share it with them. And don't forget to give us a follow. Don't even think about it, just do it. Ellie, thank you so much for joining me today.
I've loved being here.
And thank you too to Joel, Maya, Anna, Bella and Veronica for sending in your questions. We absolutely love hearing from you. So please send more. If you have a question you want answered, then send it over to us via Instagram or email. Our details are all in those show notes. Okay, that's bye for now, my lovely listener. Take care of yourself and your skin. Wear your SPF and see you next time at the After Hours Skin Clinic. As always, this podcast is for informational purposes only and is not a substitute for medical advice. Please consult your healthcare professional before making a change to your treatment.